Okay, here in part 3, we're going to talk about how pressure and flow are regulated. Basically, we've got systemic regulation. Most of that is regulating blood pressure by vasoconstriction and vasodilation, but also by regulating blood volume. The more blood volume there is in the vessels, the higher the pressure will be. And then we have local factors. Vasomotion at the local level is going to regulate flow. So we can constrict and dilate our arterioles, open and close our precapillary sphincters to have local control of flow. So systemic regulation regulates flow body-wide. Local regulation regulates it to a specific tissue or organ. Other terms for local control: autoregulation or intrinsic regulation. This is going to be affected by things on the local level, whether a tissue needs more oxygen because its metabolism's higher, or because tissues were traumatized and you have inflammation going on. There are humoral factors. Remember that humoral simply refers to chemicals other than hormones that are flowing through the blood. So if CO2 goes up, then you're going to increase blood flow. If oxygen is high enough, then maybe it will decrease. So those are examples of humoral factors. And some of our humoral factors are specific regulatory chemicals that we'll look at. Our extrinsic control is either the nervous system or the endocrine system. So you have neural control. Remember, that's going to be your autonomic nervous system. So you do need to go back to that chapter and review autonomic regulation of blood vessels and the effects of both norepinephrine and acetylcholine if it has an impact. It's mostly norepinephrine. And hormones, which include epinephrine and norepinephrine, but there are other hormones as well. So in terms of local control, we're going to control vasomotion. Remember, that refers to vasoconstriction or vasodilation. There are specific things that cause vasoconstriction, and there are certain things that cause vasodilation. Vasoconstriction can be triggered by secretion of small peptides called endothelins directly from the endothelial cells. So if endothelial cells are damaged, for example, they trigger what's called a vascular spasm because endothelins from the endothelium diffuse not into the blood but backwards into the tunica media and trigger vasoconstriction of the smooth muscle. This is great in terms of hemostasis. We've already studied that. We know that the first phase of hemostasis is that vascular spasm, and now we're learning how it's done. Damaged endothelium secretes these small peptides called endothelins. There's some evidence that endothelins are secreted chronically, so that endothelium is constantly talking to its own smooth muscle and telling it to constrict a little bit. But that would be increased if they were damaged. The myogenic response, notice that's listed for both vasoconstriction and vasodilation. The myogenic response has two stages. Smooth muscle is peculiar in that if you just stretch it, it triggers it to contract. This is called the stress response. But if smooth muscle, once it's done contracting, and a spasm of smooth muscle can last, many seconds. So it's going to contract, and then it's going to go into its relaxation phase. And as it relaxes, then the vessel dilates. So stretching smooth muscle causes a myogenic response. We call it the stress relaxation response. The stress response, when you stretch smooth muscle, it contracts. And then the relaxation phase that immediately follows it, the smooth muscle relaxes. When it contracts, it constricts. When it relaxes, it dilates. Now, look at the list for vasodilation, and you see a number of different chemicals that can trigger vasodilation. Prostacyclin, which is one of those eicosanoids. We studied them very briefly last semester. They're just little fatty acid derivatives that are secreted from the endothelium, and prostacyclin and nitric oxide from the endothelium can block the constriction of the tunica media. That is, they prevent contraction of that smooth muscle. Histamine can be released in an inflammatory response. Likewise, it prevents a vascular spasm from occurring. The vessels will dilate. That's going to increase blood flow through that tissue. And then a reactive hyperemia can occur if you've cut off the blood flow to an organ. Then once that blood flow is reestablished, it flushes with excess blood. That's a reactive hyperemia. And the best example of that is when you're out in the cold and you cut off the blood flow to the cutaneous plexuses of your skin, that's the blood supply to the base layer of the skin, then you can imagine that those poor little skin cells, even though they're so cold, are clamoring for blood because they're not getting any. Because if they got blood, you'd lose too much body heat. So once you come back in from the cold into the warmth, you reopen those capillary beds, and every single one of those precapillary sphincters is open and waiting for that blood, and so you just get a flush of blood and your face turns red. That's reactive hyperemia. All right, so continuing our story of regulation of pressure and flow, there are some problems associated with blockage of flow. Atherosclerosis is specifically assigned for you. Your book does a good job. I'm not sure about that page reference, but atherosclerosis is a blockage of a vessel due to the development of what we call a plaque, an atherosclerotic plaque. And generally this is from the accumulation of fatty deposits associated with having high blood cholesterol, but it's also triggered by inflammation, and we don't understand completely all the factors involved. It seems like there might be a viral infection in arteries where those little plaques form. So you start with inflammation, possibly from viral infection. Macrophages respond by collecting at that point of damage. They deposit lipids. You get some blockage. Stenosis just means narrowing of a vessel. You can have stenosis of valves as well as arteries. And then once you have some blockage and you've slowed the flow of blood, then potentially you could have a clot formed at that site. If it's in a major artery, that clot can actually block that point. That would be a thrombosis. A thrombosis occurs when a clot forms and stops the flow of blood at the point where the clot forms. Now, that thrombus can also dislodge, and then it becomes an embolus, and it can cause an embolism. And we'll study that later on. One of the issues associated with plaque formation is it thickens the wall. Specifically, it builds up an abnormal deposit between the endothelium and its own smooth muscle. And I told you earlier that endothelin is a little peptide that talks from the endothelium to the smooth muscle and tells it to constrict. But you also have nitric oxide, which tells it to dilate. Those plaques don't stop the endothelin signal from getting through, but they do stop the nitric oxide signal from getting through. So vessel wall, the smooth muscle of the vessel wall should be getting two signals, one saying to constrict and the other to dilate. When you have a plaque, it stops the dilating signal from getting through, and the vessel tends to constrict. So first you have this blockage from this plaque, and secondly you have abnormally excessive vasoconstriction, and those two factors together are going to reduce the flow of blood, but they're also going to boost the blood pressure. All right, so with local control of vasomotion, we're going to see that dilating or constricting of the arterioles within a specific area, a set of capillary beds, is going to be regulated by local factors. So if a tissue is more active, you want to increase blood flow. If it's a resting tissue, then you can safely decrease blood flow. How do the blood vessels know what the local metabolism is? And one of the things is that when metabolism is high locally, oxygen is depleted and carbon dioxide builds up, and that excess of carbon dioxide can increase local flow. But there's actually a specific factor that has some medical applications, and it's adenosine. Now, I know you remember that adenosine is the A of ATP, and so you wouldn't imagine that you would want adenosine leaking out of your cells because you need it to make ATP. But it turns out that adenosine actually is specifically pumped out, not pumped, but there are channels for adenosine that allow it to leak out of cells to a small degree. And that tiny amount of adenosine leaking out of cells is a signal to the neighboring blood vessels that they need to dilate. So adenosine is a metabolite. It comes from active cells. It induces vasodilation. That's going to increase the flow of blood to that capillary bed. The adenosine is going to get diluted out as the blood flow increases, so lower adenosine will cause vasoconstriction. Now, the medical application of this is that adenosine receptors on the blood vessels are blocked by caffeine. So when caffeine binds to adenosine receptors and blocks them, it causes a vasoconstriction. Now, in the brain, adenosine likewise is a metabolic factor that signals changes, but in the brain it's not just the blood vessels that are affected. There are centers in the brain that regulate your wake-sleep cycles, and an increase in adenosine levels causes fatigue and sleepiness. So we use caffeine to block the signal of adenosine so that we can stay awake and study late at night. So the adenosine signal is blocked by caffeine, but the cells respond to the loss of the adenosine signal by upregulating. That means the lack of signal coming on those adenosine receptors causes cells to produce more adenosine receptors. And then the caffeine effect is reduced. You've physically responded to a certain level of caffeine, so it takes more caffeine than it used to keep you awake, and before you know it, you're drinking 4 or 5 cups of coffee just to maintain a normal state. So when you go through caffeine withdrawal, if you quit cold turkey and you have all these extra adenosine receptors, then the vascular effect predominates. Those blood vessels dilate like crazy. In your dura mater, the dilation of those vessels causes a pulsatile headache, a migraine headache, and that is why caffeine withdrawal causes headaches. So the medical application here is if you have patients that are heading for, usually it's going to be elective surgery, and they're told not to have anything by mouth 12 to 24 hours before surgery. If they're caffeine addicts, they skip their coffee that day, then after the surgery they wake up with a pounding headache. So probably 50% or more of post-surgical headaches are caused by caffeine withdrawal. So if you know you're going to have surgery, then you should probably slowly withdraw from your caffeine addiction. Another local factor, and this again relates to people who've put on excessive weight, you build more adipose tissue, but it's also true if you build more muscle mass, angiogenesis can occur. Angio refers to vessels, genesis means production, so you actually grow new vessels when you increase the size of a tissue, whether it's muscle tissue or adipose tissue. And the opposite of that can occur. Of course, if you don't use it, you lose it, so you also have atrophy of those vessels over time. This obviously is not a very rapid onset thing, and there are medical applications here too in terms of cutting off angiogenesis in tumors so that you can cause tumors to shrink or fail to grow larger if you could just control the angiogenesis. At the level of individual capillaries, this is where local control hits closest to home. It's the flow of blood through capillaries that determines nutrient and waste exchange. And so those precapillary sphincters respond only to your local needs. So if you increase waste, that's hypoxia, that's low oxygen, or hypercapnia, that's high CO2, then that's going to cause the precap sphincters to open. The tissues will be well perfused. That means great blood supply. That will carry off the CO2 and provide more oxygen, and then that triggers the closing of the precap sphincters. And that works great at the local level in systemic tissues. In the pulmonary capillaries, things kind of work the opposite, because when you have more oxygen in the lungs, well, that's when you want to increase perfusion, the flow of blood into that part of the lungs. So when you take a deep breath, you get more oxygen in the apices of the lungs, and that increases blood flow to those regions of the lungs. So the pulmonary precap sphincters work in an opposite way to the systemics. High oxygen causes opening of the precap sphincters, and low oxygen causes closing of them. So the problem here is if you have lung disease that results in poor ventilation so that the oxygen level is low, then you're going to have low blood flow to that poorly ventilated part of the lung. So if you have a patient with tuberculosis and they have scar tissue preventing the flow of fresh air into some lobe or lobule of the lungs, then they also have low perfusion. And that means that if an infection sets into that lobe or lobule, you can still get fungal spores in there, then there's less blood flow, less likelihood of getting a good immune response, because the elements of the immune system have to be delivered through the blood. And so you're going to get persistent chronic infections in the lungs of people who have damage due to either TB or blockage due to tumors or whatever. Additionally, if you have excessive blockage, then you're going to have such low flow through the lungs that you're going to have pulmonary hypertension. That is, the pressure's going to go up because you have such high resistance. And that can cause failure of the right side of the heart. The blood literally backs up into the right side of the heart, which means, of course, it's going to back up from the left side as well. So you're going to have congestive heart failure. All right, so that's the local regulation. Next, we're going to look at systemic control. We'll do that in part 4.